So, good morning to everybody and everyone. Just to check, do we have Stuart on the phone online now? Yes, we see it. Okay, so all the speakers are here. We still have some participants on the go, about to join. So they are more than welcome. So I'm Marc Lange from EHTEL, one of the two co-organizers of this webinar. With Emma, and I will leave Emma a few words of introductory. For those in this audience, we have quite a number of members of EHTEL, so they are more than welcome. And my few words now is not for them, but for the members of EMMA, and for those who are not who are working on projects and do not know EHTEL yet. EHTEL is a forum for all type of stakeholders, and we are dedicated to work with these stakeholders on digital transformation of healthcare system. We are part of the SCIROCCO project. You will hear more about it soon. And so we are very pleased to team up with Emma, because we our respective organizations, we are willing to we are starting collaborations on management issues related to the digital transformation, and we would like to run and combine our resources and join members to develop knowledge and share knowledge and build capacities on managing digital transformation. So that's all on my side. So Usman, happy to hand over to you.
Thanks, Mark. Good morning, everyone. My name is Usman Khan. I'm the Executive Director here at the European Health Management Association. I'm very, very happy to be working with Mark and EHTEL, this partnership that we've developed, and this is one element of it in terms of the webinar this morning. EMMA is a work organisation focused on excellence in healthcare management, and we bring together the people who teach health managers with health management practitioners and policymakers to focus on improvement around health management. A particular interest today is the fact that the Secretariat at EMMA is working on another Horizon 2020 integrated care project, the SUSTAIN project, and we feel that there could be interesting connections between SCIROCCO and SUSTAIN, which we hope that this webinar will be a sort of starting point for. We'll also be taking forward the partnership with EHTEL at our annual conference in Budapest from June 20th to 22nd. And also in terms of the working we're doing, having established a special interest group on intermediate care, and also another special interest group on digital health. So I won't take up any other time other than to welcome those members and network members from joining this morning and hearing the presentation.
Thank you, Usman. We also need to ensure that everyone is aware of this. So we also need now to everybody, or every participants, that on one side we will be recording, and we are recording this session, and our intention is to publish it on the SCIROCCO website for enabling others who cannot participate to benefit from this session. So if someone has an objection, please drop an email on the drop a sentence in the chat box, so that we can pay attention to that in the course of the webinar. So I'm happy to not to delay further entering into the content, and I'm happy to hand over the words and the floor to Andrea Pavlichova, who will be introducing briefly the SCIROCCO project, the maturity model that has been developed, and the online tool that is supporting the use of this maturity model. Andrea, it's yours.
Thank you very much, Mark. So good morning, everyone. My name is Andrea Pavlichova, and I am the project coordinator of the SCIROCCO project, and I work as the engagement manager at the National services, national healthcare services in Scotland. So in my presentation today, I will just briefly introduce you the main objective and the achievements that the achievements so far, and then I will hand over to Stuart and Esteban to walk you more in details in terms of how the structure of the model looks like, and more importantly, how the tool has been tested so far in the real life settings in the Basque Country. Next slide, please. So just to start with a bit of introduction to the project and who we are. So we are currently in our last year of the project. The project started in April 2016 and we are finishing this November 2018. We are a relatively small continuum of 5 regional and national healthcare authorities in Scotland. Then we have Norrbotten in Sweden, Basque Country in Spain, Puglia region in Italy, and Olomouc region in Czech Republic. And we are also supported by our academic partners who are primarily responsible for the areas of evaluation and technical development of the tool. And then we are also pleased to have on the board the membership organizations such as EHTEL supports the dissemination and exploitation of the project findings. Next slide. So why SCIROCCO and what we are trying to achieve within the project? So I haven't mentioned at the beginning that this abbreviation actually stands for Scaling Integrated Care in Context. So it's quite obvious that the main challenge or the main objective we want to achieve is to address the challenges of scaling up of integrated care in Europe. And the main argument or the main driving force of the project is that to support the successful scaling up of integrated care, we need to have a better understanding of the local conditions and local context for integrated care, so that we can better understand what are the needs and requirements of the local environment to better tailor the information and the evidence that is needed to actually help the regions towards the implementation of integrated care. And we believe that once we basically understood better what is the current stage or the maturity of a healthcare system in regions for European for integrated care, that this will basically help us to better tailor the knowledge transfer and the flow of information for these regions and authorities. Next slide. Next slide, please. You all probably, you would all agree with me that the issues of scaling up and implementation of integrated care are very complex processes. And when we were looking for, or when we were at the stage of developing this project, we ran a couple of literature reviews when it became very obvious that currently we are actually lacking tools and frameworks that can help us better to understand these very complex processes of transformation. And that's where we kind of like felt that it will be really added value at European and also national and regional one if we start working on some tools or frameworks that can help us to facilitate these processes. Next slide. What is important to mention is that I said that the project started in April 2016, but actually that whole work on the development of the tool has started much earlier in 2014 as part of the initiative called European Innovation Partnership on Active and Healthy Aging. Many of you are members of this organization and have actually contributed to the starting point of the SCIROCCO tool. So within that initiative, we started working on what we've called at that point maturity model for care, and that served for us as a sort of like a conceptual model for integrated care that help us to understand the current progress of regions in the area of integrated care. So we've run a couple of interviews, face-to-face interviews with the regional and healthcare authorities to understand where they currently are in terms of integrated care, and more importantly, what are their ambitions moving forward. We have then clustered this learning in what we call domains for integrated care, and you will hear more from Stuart in terms of a couple of examples how that has been defined and developed. With the next slide, please. Within the SCIROCCO project, we are trying to basically bring this work that started back in 2014 further and look much more in details on validation and testing of the maturity model in real life settings. So one of the driving or factors of that testing is actually moving this conceptual model to an online self-assessment tool for integrated care. And you can see slide all those 12 domains that are key. You'll hear more about the domains in the following presentation. Next slide. I think what is important to highlight is that the SCIROCCO tool is available online, even though it's not in its final stage. Actually, very early at the beginning of the project to actually make sure that we can with the users, that we can define the tool based on the people's needs. So it's really we have adopted very center approach and very bottom-up approach to the development of the tool. So everyone who is interested to test the tool and see much more in details how the tool operates can just simply access the link, register, and then just basically test and play with the tool. Here on this slide you can see example of one of the domains. So once you check the tool, you are able to learn about what this domain capture, and then there is also associated assessment scale from 0 to 5, which gives you the opportunity to allocate the maturity of your situation along each of the dimension. Next slide. And once you actually allocate that measurement of maturity along each of these 12 dimensions, you can get at the end this spider diagram. So that's basically the visualization of the self-assessment outcomes. And again, I won't drill in details in terms of how that's been run, because you will hear from Esteban how it was used in the real life settings. Next slide. And I will just, in the second part of my presentation, I'll just briefly outline the different purposes that the tool can be used or tested so far. So just to give you a bit of information about the potential application and how can you benefit from the tool to your national and regional levels. Next slide. So the first objective of the tool, or the first purpose of how to apply the tool, is to assess the maturity requirements of good practices. Here, I think what I would like to highlight is that we are not applying the tool to evaluate good practices. So we are not trying to say if the good practice is good or bad, but we are trying to understand what are the critical elements of the good practice that are necessary for the implementation of this practice, but also for its transferability. And we call these elements features. And as you can see in this this illustrative spider diagram, each of these domain is basically going the assessment at each of these domains give you the opportunity to identify those elements of transferability much more in detail. So in case you are a potential adopter of a good practice, you can actually access the information on the requirements that you need to have in your healthcare system in case you are interested to transfer this good practice. Next slide. The second purpose of the tool is to assess the maturity of the healthcare system, I mean, here again we are not looking at the information in terms if the particular healthcare system is good or bad for integrated care, but we are trying to see how mature you are. So what are the areas of integrated care where you are very strong, and on the other hand, what are the areas which you are probably lacking, and that's basically where the potential improvement and is basically necessary. And the last application of the tool, Stefan, if you can just keep clicking. Yeah, thank you. The last application of the tool is to facilitate multidisciplinary discussions and negotiations. So here you see again example of the Basque Country, where the different stakeholders have conducted this self-assessment and have shared their individual perceptions on how they see the progress or the maturity of their healthcare system for integrated care. Next slide. And if you bring all these individual perspectives together, you can get what we call like this composite diagram, which basically brings all these individual perceptions together and allows you to have the information on where the stakeholders have the biggest agreement, or on the other hand, the biggest disagreement, and create this area of disagreements where then this targeted conversation or discussion between the stakeholders take place. And that's basically what, from our experience so far, is the biggest added value of the tool. So it's not the tool itself, I would say, but it's that ability to facilitate the discussions and perceptions of stakeholders. Next slide, please. I would like to conclude today just by outlining the next steps. So these three different purposes of how we use the tool, and currently we are basically moving to the stage where we are bringing all these steps together, and we are trying to find out or test how the tool can potentially also support the very targeted knowledge transfer and tuning and coaching activities between the countries, between the regions. So here basically is that once you have the understanding of the local context for integrated care in one region, and you compare with the other regions in terms of your strengths and weaknesses, this should allow us to actually make the better connections between the regions and make the knowledge transfer much more effective. And my last slide to conclude is to basically just emphasize that that a message which what I mentioned at the beginning, that the tool is available online. It's available for testing for a certain for a long time now, and you can see from these following slides that we are really very pleased by high engagement and interest from the regions and projects around Europe who are involved in the testing and refining of the tool. So thank you very much for your attention. I think that will be me for now.
Thank you very much, Andrea. That was absolutely perfect overview, and you kept also perfectly to time. We're now moving on to Anderson, who, Stuart, you're going to be talking a little bit more about the maturity dimensions.
Yeah. Okay, so I'll wait till the slides come up here. You can hear me okay, yeah?
Yes.
Okay, so the purpose of this talk is really just to zoom in on the maturity dimensions, just to give you a feel of how they're constructed and so on. It's not really to talk about the tool at all, because Esteban is going to talk about the direct experience in the Basque Country of the use of the tool. So I'm more going to be talking about the model. So if we go on to the next slide. So this is the conceptual model that that Andrea showed in the previous presentation, and as you see, there are really 12 dimensions here, and the purpose of the dimensions is in some way to structure discussion and elicitation of knowledge about the health system. You know, so when you're looking at a health system and you're thinking about its maturity, then these dimensions are really oriented to structuring individuals reflecting on their understanding of the way that the health system functions at that particular point in terms of integrated care, and also to help structure discussion amongst people and consensus reaching and negotiation about actually the view of the health system. So in a sense, what it is it's a tool to structure reflection and discussion. So we move on to the next slide. So the maturity model really came out of the EIPonAHA, and the dimensions were developed by clustering issues that arose from 12 semi-structured interviews across the EU, looking at different levels of development. Some were very well developed in integrated care, others were less well developed. but the idea was to really look at those semi-structured interviews and then cluster and bring together the number of dimensions. So the number of dimensions being 12 just happens to coincide with the number of extended interviews that were done. But it could have been 10, it could have been 14. It's just the way that the clustering worked out. The way that the model is structured, the description of the model, is each dimension has a short narrative and then a list of indicators of maturity in that dimension. And that was the way it was developed as a kind of conceptual tool for discussion. As part of the evolution towards building a tool, it was also extended with scoring scales for each of the dimensions. So the idea was to put essentially a 5-point scale plus a 0 if nothing had been done really in that area. And one of the key things in the SCIROCCO project was really to look at trying to do some validation work. So the very first thing that we did within the SCIROCCO project was to run a Delphi process to look at doing a qualitative validation of the work. And so we ran Delphi process with 55 experts, and there was strong agreement amongst the experts on the relevance of the dimensions. And then we looked at the grading scales in detail, and I think we took 3 iterations really to refine the grading scales until there was agreement on the face validity of the sequencing of the grade scales and also the relevance of the individual points on the grading scale. So we have reasonable confidence in terms of tapping into a fairly wide group of experts in Europe that the model has some face validity. There's more recent work in terms of looking at the use of the model. Now we've got more data because of the tool. I'm not going to cover that. It's still really in development, but we have reasonable confidence that the tool in use actually gives us reasonably reliable answers. So if we go on to the next slide. So the dimensions are really quite heterogeneous, and they identify these key areas where significant barriers and facilitators towards achieving integrated care kind of are located. And I think the nice about it is grounded in the direct experience of the health systems that have been attempting to implement integrated care. The other thing is that the dimensions aren't independent, and that wasn't ever intended to be the case. So there's quite a lot of dependency and synergy between the dimensions. And actually, to some extent, we haven't done a lot of this work, but this is something that we're looking at the moment in the tool, which is to look and see at some of these potential dependencies between the dimensions and actually look at that in terms of the integrity of the responses in the tool. But we can come back to that if it's interesting. So we go on to the next one. So the next 9 slides are really kind of delving into 3 of the different dimensions. So, and each of them kind of, if you like, is an example of what's there within the maturity model. I'm not intending, these are quite word heavy. So the first dimension I was going to look at is population approach. So this is the kind of narrative that you can see. So here, this is stressing the importance of trying to understand the demands in terms of integrated care at population level. And then, if you like, here is the narrative, and then there are these indicators. So the indicator that there's need for understanding and anticipating demand in the system, looking at improving the resilience of care systems by using data sensibly, and then taking steps to divert citizens into more appropriate and convenient care pathways based on their preferences. And then also predicting future demand. So all of these things are seen as critical elements of a population approach. And then this was when we started to develop the tool, we started to develop a scoring scheme that to some extent would try and capture the development of the maturity of the health system along this particular dimension. And so if we move to the next, Stefan, then here you can see this is an attempt to kind of linearize this. So if you like, the the indicators are not linear. They're a set of characteristics that you might see present or not present. And this is looking at a particular, if you like, evolutionary approach to developing population approach. So we don't need to go through all of it, but again, it's really a 5-point scale. And so here, if we look at point 2, it's saying that there's some experience with risk stratification and it's used in a systematic way for certain parts of the population, so high categories. So for example, if we look at when Scotland was doing this, it has population stratification around the anticipatory care planning. So there, it's already used for certain high risk groups. So the Scottish experience of this would be, in terms of population approach, would be at least at 2. And then looking at this, saying can 3 says, can we target the stratification approaches to frequent service users? And then eventually at level 5, then there's whole population stratification fully implemented. And I think Esteban might be able to confirm this, but I think the Basque country is probably round about there in terms of that, in terms of their dimension. So it's there's an evolutionary approach along the dimension that's kind of built into the scale, and to some extent that channel direction, but it doesn't channel it too much. To find a nice balance between what we think is development without necessarily it has to be done in a particular way. So can we have the next slide, Stefan? So broadly, if we look at the dimension, it focuses on the capacity of the organization to identify them and to meet it. Yeah, and it's not independent of the other dimensions. So it needs good data, so there are implications for ICT infrastructure. The organization needs to be ready to change repeatedly to meet changing patterns in health demand. And to some extent, this readiness to change needs to be built into the organization, and there needs to be the acceptance that there will be repeated changes in order that the service structure meets the demand structure, and that taking population approach helps people become aware of that. Innovation needs to be well managed to enable the adoption of new practice, and citizen empowerment to be developed to engage citizens in achieving the change in services, because one of the things that you need to be able to do is to be able to have a willing population who are able to divert into different modes of delivery. So that's population approach. So next, Stefan. So innovation management. And again, this is saying that many of the best ideas are likely to come bottom up. So there needs to be some way of capturing the experience of people at the front line who are involved working with the service, but also to combine that with ideas coming from other innovation organizations. So the idea is to try to develop innovation in a way that identifies real things that will give you benefit and will achieve adoption and change within the organization. So this is about looking at how well developed the innovation management. And there's a bunch of indicators there. So learning from inside the system as well as from other regions, involving regional and social care authorities in terms of forming collaborations and reaching this, looking at how one does procurement as well. So if we go on to the scoring scale, next slide, Stefan. So here, if we look, innovations are captured, say level 2, and there's some mechanism in place to encourage knowledge transfer. So if we look at that, then if we look in say the health system in Scotland, which is the one I'm most directly familiar with, then there was a scheme, say 10 years ago, or say maybe 5 to 10 years, which encouraged lots of innovation, but there wasn't really a way of consolidating. So there were a large number of very small process changes and other innovations. But actually, there was very little coherence across the whole in terms of managing that. And what's happening now is there's more formalized approach to these things. So there's the idea that actually it's not really the number of innovations, because at one point there was a very strong emphasis in saying, you know, you should innovate, you should have 5 innovations a year or something like that for each of the units. But rather looking at the impact and seeing how it changes the organization and what happens. So if you look, the progress is towards a more organized and formalized innovation process where it's built into the organization. So you get to the higher levels, you need to think about that. So next, so here, matching services to demand, you need continuous innovation to improve service delivery. And the people involved in service delivery understand the issues and need to be engaged and be willing to change, but they also need to understand that it may be that the way that services change won't be precisely to solve a particular problem that they've experienced, but rather there'll be some kind of generalization process in order that the good practice or the change in practice can spread through the organization. And there will be lots of ideas for change, but these need to be managed effectively to get meaningful change. So next one, Stefan. So this is the final one we're at, so capacity building.
Stuart, sorry.
Yeah.
Sorry to interrupt you. Time is passing here, and we would like to open the floor to some questions. So, can I ask you to not to cover this third domain and to stay with the 2 domains that we just described: population management and innovation management.
Sure,
so that then we open the floor. And of course, we will share the slides after the call. So
if we
can
flip forward through the next 3, I'll just finish. There's a slide, I think. So
yeah, if you can, okay, if you can just go to the conclusion, then great. Thank you. Thank you, Stuart.
Yeah.
Stefan? Conclusion.
Yeah, okay, keep going. Yeah, there's next one.
Yep.
Okay, so the maturity model framework that identifies these key focus areas, the dimensions give broad coverage of the areas of concern and the adoption. And the dimensions aren't independent, and there are complex interdependencies. You know, so a population approach depends on maturity and ICT. And the maturity model provides a means to capture reflection on the maturity of a health system systematically. And it provides the basis for a range of activities that help identify the way forward in adopting integrated care. And to some extent, that's what Esteban will illustrate in the Basque Country experience, because the maturity model underpins a methodology and approach to reviewing the maturity of the health system. So that's it.
Thank you.
Okay.
Thank you, Stuart. So, any questions on to Stuart and to Andrea if needed? But now you have a picture on the project, on the maturity model. You will have a picture on the tool in a few minutes. So, any questions from the floor to Stuart or to Andrea? Don't forget that you are all muted so far. So before asking questions, unless you have asked question on the chat, and then Diane will take care of it. If not, please unmute you and ask your question, and we will run this for 5 minutes. Okay, so let's keep the questions for the end of the presentation. Now then to hand over to Esteban from the Basque Country, from Conigune from the Basque Country, who will put all this a bit more to life with practical example on how the stakeholders in the Basque Country have been using the tool to assess the maturity of their own healthcare, which is already a pretty well mature healthcare system, as some of you will knows and others will discover. So Esteban, the floor is yours.
Okay, thank you, Mark. I hope you see my screen.
Yeah.
Fine. So I'm going to spend a few minutes talking about what was the experience here in the Basque Country using the tool to assess the maturity of the system towards achieving real integrated healthcare. So Basque Country is a small country, 2 million people, a little more than 2 million people, 200,000 in the north of Spain, near the French border, and it's a beverage health system. It's funded by taxes. It's in fact the highest per capita spending in all Spain in terms of health, and it covers the nearly 100% of the population. Now, in 2018, it's organized in 13 integrated care organizations. So in theory, we are quite integrated healthcare systems, and those integrated healthcare organizations, of course, comprise acute hospitals, primary care centers, and altogether there is more than 30,000 healthcare professionals employed by the Osakidetza healthcare service in the Basque Country. So this, as I said, since 2012, there was a huge effort trying to blur the boundaries between primary care and hospital care mainly, but also mental health and others. And from previous independent hospitals and primary healthcare areas, we achieved these 13 integrated care organizations through those 4 years. And the idea is that we should try to optimize synergies between the different healthcare levels, and of course have more coordinated, more efficient and higher quality care, trying to avoid overlaps and gaps between care, and achieving a more seamless continuous care for the patient trajectory across the system. So these are based on 3 pillars. First, an integrated governance, so that there's only one management for all healthcare units within the boundaries of our integrated care organization, ACO. And of course, one locus of responsibility, one general manager taking decisions all over the issues around the healthcare provision process. The second point is, the second pillar is population approach. The whole population is stratified, trying to identify the risks or their needs for healthcare, so trying to have a public health approach in that. And each integrated care organization has the responsibility for the health of the entire in a given undefined geographical area. And there is an effort to try to coordinate with social services, which are dependent on local authorities, not the healthcare organization. The third pillar is culture and values, which is the most difficult one, as you can imagine. And the idea is to try to change from this different silos culture in each of the hospitals or primary healthcare center, common organizational culture within the ICO. The final point is trying to, instead of looking at process indicators to evaluate each of the units, trying to use health-related outcomes with a bundled evaluation for the whole population of the target area of each of the ICOs. Of course, all of these things at the end is trying to make all the different units to work together, acute hospitals, primary care, and so on and so forth. And for that, different strategies, many of them based on ICT tools, the Unified Electronic Health Record or Unified Program for Nurses Activity, e-prescriptions, and so on and so forth, have been implemented in the Basque Country, but also some other managerial kind of strategies that I do not have time now in this seminar to go on. But the exercise I wanted to share with you is, well, this happened from 2012 to 2017, and in 2017 we ran an exercise to try to assess the maturity of the system, the real maturity as perceived by different stakeholders. So we identify 10 different experts, asked them to use the SCIROCCO tool to have their own perception on the real maturity of the system, and then we try to collect those information and use the individual results to build a kind of a common view, a consensus approach to have their final assessment of the maturity from their perspective. The profiles of the 10 people that we got in this exercise are people coming from different backgrounds, different responsibilities, some frontline professionals and some top managers at the central headquarters of Osagdetsa, from internal medicine's unit chief to primary carers, or one of the person responsible for health and social care coordination at the past country level, and so on and so forth. You have the slides there, and believe me, there were very different backgrounds, different roles, different responsibilities. This is just a snapshot of the individual results of the self-assessment by some of those people. We have the 10 different assessments, and I would like to stress that you can see that they scored the different dimensions very, very differently. So after that, you can see that even if there was a variation, you can see that the scoring of the different dimensions was very different. For example, we have high scores in breadth of ambitions, on population approach, and quite a low in finance and funding, or removal of inhibitors. But I would like also to stress that there was different variability on the answers in different dimensions. For example, in population approach or in finance and funding, the individual scorings had high variability, whereas, for example, in readiness to change or breadth of ambition, people gave more homogeneous responses. So there was, as I say, differences in the perceptions on the maturity of the healthcare system in the past country after 4 or 5 years of work trying to achieve this integrated care situation. So we tried to understand why there was so much variability. At the end of the day, we reached the final conclusions that not all of them understood what the dimension meant equally. So people had different understanding of what were asked to score. Second, the dimensions are like of complex constructs. They have several issues within each of the dimensions to assess. So each of the stakeholders gave different weight to each of the subcomponents of the dimensions, the features, as Andrea and Stuart said. And finally, of course, there might be agreements about the perspective according to the position of the systems, their responsibility, their personal experience. So this is a quite complex picture of why there was variability. But this is not a problem. This is the idea. So we organize a workshop to try to reach this consensus. And this is more or less the methodology that we use. We split 10 people in 2 groups, working groups, and we tried to make both of them to reach an agreement on them. And then each of the groups selected one, let's say, spokesman or spokespersons, and those 2 again met between themselves and tried to reach an agreement to have one final agreed consensus picture diagram on the perception of 10 stakeholders of the maturity of the health care system in the Basque Country towards integration of care. So as you can see here, you can see the final picture that one of the groups reached. This brown line is their final scores for each of the dimensions. If the others are the previous individual scores each of the 5 members had given previously to the dimensions of the system. And this is the exercise in the second. Again, this is the final score. They agreed. And these ones are the previous individual scores. So it was not difficult for each of the group to reach an agreement on the score. They did it in about 40 minutes, I would say. And this is the final consensus that the 2 spokespersons of each of the groups reached after again half an hour, 40 minutes discussion. And you can see that at the end of the day, this group of people thought that we are quite high in terms of the breadth of ambition for integrated care in the Basque Country, quite high on population approach, and not so much on innovation management or funding and finance or citizen empowerment. So at the end of the day, we reached a final consensus in this negotiation process. And well, as conclusions of this exercise, I would say that it was possible to reach an agreement among very different stakeholders working in the system on what is our situation. It was not so difficult at the end to agree on those discrepancies, even if the starting point of the individual scoring was very different, as you could see. And at the end, well, we can have a view of that there has been quite a progress in the last 4 years towards integrated care in all dimensions, but not homogeneous in all of them. So we have been able to identify areas for improvement in exercise. One is citizens' participation and empowerment, and the other one would be innovation management. And as a methodological conclusion, this tool is a useful tool to provoke discussion, to provoke and enhance negotiation, and to, at the end of the day, understand better what is happening in our system and reach final decisions on what are the improvement areas, how should we prioritize our future efforts, and so on and so forth. So thank you very much for your attention, and I open for your questions and clarifications.
Thank you very much, Esteban, for this lively presentation. That's really real life, and that's a fabulous experience. And I'm always very impressed to hear how the tool and this maturity model is structuring the discussion within a multi-stakeholder platform. That's on my side. Usman, do you have any comments? And then we will, of course, open the floor. We are on time. Thank you, and I appreciate that very much, Esteban. Thank you for this too. We have now 10 minutes foreseen for discussions. So and for question and answer. So happy to open the floor to all of you verbally if we don't have questions in the chat box. But Usman first, happy to have some questions on your side.
Thanks, Mark. And I just say, I mean, all the presentations have been really, really interesting, and Esteban, in particular, being able to just see how the tool can be used to assess progress. And I was also interested, just when you're talking about some of the challenges in terms of whether all the stakeholders were understanding the domains in the same way. Do you, maybe just opening it up, do you feel, Esteban, that if you didn't have the SCIROCCO project, what difference would it have made? Because you've already, the healthcare community, committed to structuring yourself to deliver integrated care. So what level of difference do you feel having the project has made?
Well, maybe two things I would say. First of all, I think this is a very interesting tool for assessing system development, but not only to assess system development, but also to help system development to occur. So it's a tool that can be used to engage relevant stakeholders, to organize managerial discussions, and so on and so forth. The second point is that the way this tool was developed was a bottom-up exercise. As Andrea described, this was developed doing grassroots interviews with people that have been involved in different regions in Europe in integrated care and so forth. So if you compare this tool, the dimensions of this tool, with other tools available on the literature or even on the market, you will see that some of the dimensions, of course, are quite similar: funding, finance and funding, or e-health development, or ICT developments. But you will also find that there's some dimensions that are peculiar. For example, breadth of ambition, innovation management. Some of them are not so. And I think this is the answer to your question. This tool allows you to put your focus on things that normally isn't so much important in more formal kind of planning exercises.
Mark, I'll just come back to say, Esteban, that was a really, really clear and helpful answer, because I think what you're saying is that it has this diagnostic capability, but it's also about development and change management. And I'm particularly interested to hear that you feel that because it is strategic and systematic, it takes you into domains that maybe you'd leave to one side, and you shouldn't leave to one. It means that you're going through them.
Usman, we are losing you. Repeat again your last point, please.
Sorry, I'm not sure. I was just saying how interesting I found Esteban's response in terms of being able to say that it's a diagnostic tool, but it's also about being able to impact in terms of change management, and that this idea that it because it's comprehensive, it makes sure that you don't ignore some areas that you might otherwise do so because they're sort of slightly quieter. So it sounds very positive in terms of how you've used it to develop integrated care within the Basque area.
Thank you, Usman. So, does someone in the audience would like to raise questions to one of the speaker, or to introduce comments?
Mark, Niels Rossing has posed us a question indeed. He wants to know whether we have interviewed stakeholders from outside the consortium. And I too had a question which relates to Usman's change management comments, meaning aren't there some of the regions that are also looking at repeating the tool in, say, a year's time or a regular time in the future? So 2 questions. Did we interview stakeholders from outside the consortium? And second question, are regions looking to report their exercise with the tool?
Thank you, Diane. Thank you, Niels, for this. Andrea, can you answer to this question? You are the person who has the broadest view on this.
Yeah, I can take those questions. So first one, in terms of interviewing the stakeholders, as we were saying in the presentation, the face-to-face interviews were conducted as part of the European Innovation Partnership on Active and Healthy Aging, where we included 10 regions across Europe to in this exercise. And it was in 2016 when we were building the consortium for SCIROCCO project, and we have actually included half of the regions in the proposal directly. But as you can have seen from my last slide, now when the project is running, we are including, and we have been approached by a number of regions and organizations outside of the consortium. So in the consortium, we have 5 regional and national healthcare authorities, but through the collaboration with very funded projects and the authorities themselves, we have been able to engage over 30 regions in Europe now. And we have also been approached by organizations outside of Europe. So we have the model in Australia now. We have very good links in Canada and the United States, and also there was a recent approach from India. So we are really trying to build that community of the users of the tool, and really take on the board any feedback that we are receiving in terms of either how to shape better that conceptual model, better definition of the domains and assessment scale, so that aspect of usability. So what regions can do with the tool, because actually picking up on that second question as well is that we actually explore the potential of the tool as we go. I would say as well that we are learning a lot from that experience of regions. When we were at the stage of designing this project, I don't think that we were aware of all of its potential. And one of the feedback that came back as part of the focus group and the communication with the testing region is actually around the fact that you can repeat the application of the tool, and there are regions who are looking at it, particularly Flanders and also the Skåne region in Sweden, where they were picking up on this added value of the tool, that once you repeat the assessment, you can actually see yourself internally how you progress the maturity across the various dimensions. So it's definitely the intention to test it for that purpose as well.
Thank you, Andrea. I see now questions coming. Diane, can you introduce the new questions coming?
Yes, indeed. So we have 2 questions. One is from Lena Otto in the Dresden, Saxony area, and the other is from Ellie Breedveld. Ellie, sorry, I don't know where you're from quite quickly, but the 2 questions are quite linked. One has to do with how we compare the maturity in different regions, seeing that the consensus meeting is a processual exercise. So have we considered whether methodologically it's the very fact that you're a different region that means you assess your regional maturity differently? And Ellie is asking more specifically about the Basque region, about how patients or citizens were involved in filling in the test and the workshops. And I think there may be other observations on that come from, say, Sweden and Scotland. So first question, comparing how the different regions look at maturity, and secondly, involvement of patients and citizens in the exercise, particularly in the Basque Country.
Thank you, Diane. Before passing over the floor to answer these questions, it's 11, so we should in theory close the call. But if you don't mind, we will answer these questions now, and we'll postpone closing the call for 5-10 minutes, not more than that. And in the meantime, I invite you to have a look on the screen where you see the save the date for the final conference of SCIROCCO, which will take place in a few months' time, and that will give you an opportunity to learn more, to work more on the topic in October. So, Andrea, I think that the first question from Lena I see it's connected with the work that we plan to do with training and coaching, and Esteban, the question from Eli is certainly for you. So, Andrea.
Looking on that question of how we compare the maturity in different healthcare systems, I think what is important to say is that it may be basically misleading, but we are not trying to basically compare the processes as such, because what we are learning from the experience of region is that despite the fact that we have developed a methodology which is, like very unified and, making sure that there is a similar, the same approach in different regions, we've seen that depending on your local situation, regions and stakeholders approach this process very differently. And it has a lot to do with, either the way how you organize your system, but also your culture themselves. So I think that in terms of the process, it is a very flexible process, and we always emphasize that despite there is, defined process and methodology, there is a lot of flexibility how to adapt it to your needs and what you want to achieve as the organization or the system with the tool. Obviously, we are trying to, learn from the outcomes that are coming to some extent. And as we were saying, we're trying to bring these outcomes of this maturity of the assessment to inform some potential twinning and coaching between the regions. So we are trying to kind of like cluster the regions which have complementary strengths and weaknesses to see, who would be the best region to learn from. And we have developed the methodology for that as well. And we are now in the process of testing it. So I think that I may just stop here now to answering in very much in detail to see how it actually goes.
Stuart, a few words to add on this methodology question before we pass over to Esteban.
Yeah, I mean, I think the methodology is extremely important, and the tool is quite flexible in terms of how it supports methodology, and the methodology can be varied quite significantly. It allows a bit of variation in terms of the precise way that we carry things out. So I think it's quite flexible, and the tool supports it very well. But the key thing is, to some extent, to build a consensus through some kind of effective negotiation, and also to ensure that you have enough diversity in the team that you get a really good view on the health system or the good practice.
Thank you, Esteban. Sorry, thank you, Stuart. Esteban, just going too quick. Esteban, a few words to answer the question, and then we'll be able to close the call. Esteban?
Yes, just to reinforce what Andrea and Stuart said, the comparison of different health systems is not the aim. Of course, if you would like to use to it, then we have to make sure that you have very well selected representative samples of answers that are equal in all, let's say, regions and so forth. But this is not our main, has not been our main aim here. Regarding the other question, no, we haven't used it with citizens or patients. At the end of the day, the exercise we did was on the framework of the SCIROCCO project and the objectives of the SCIROCCO project. But of course, it could be used, and it would be very interesting to test it using lay citizens and patients and see what is their perception on the different dimensions.
Thank you, Esteban. Thank you. Usman, I think that we now need to close the call, so happy to hand over or to you for a final comment.
I just want to say a thank you to all the presenters, because I think it's been a very, very interesting webinar. It's given a really, really strong overview of the SCIROCCO project, and a very applied one, and I think that's really helpful. And we will now continue to connect this with the SUSTAIN project and the development of the SUSTAIN roadmap. So you can look out for further sort of emails and tweets that will enable people to be able to connect between those two projects. But other than that, I'd just like to say it's been very enjoyable. Thank you.
Thank you, Usman. And of course, you did, but there will be also for EHMA friends and members of the network, there will also be an opportunity for learning more on the SCIROCCO model during your final conference in Budapest in June, since there will be there is a session foreseen for that, and that will also be an opportunity for conversation between SUSTAIN and SCIROCCO on the topic of integrated care. So, having said that, thank you to everybody for your participation. We thank you because we did this in order to offer you something, and your participation has therefore to this webinar has therefore justified our work. So thanks a lot for this. I will not wish you a safe journey home here, but I wish you simply having a nice day, and we look forward to hearing from you or asking questions and looking on the website of SCIROCCO to find the details and the foundations, and in the future the record of the webinar if you want to share it with colleagues. Thanks a lot. Have a nice day. Bye bye.
Okay, bye now. Bye.
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 I wanted